I need to have my fast brain on with jokes and talk fast.
Here's your flaw.
Wait, is Isha still on under you, Dwayne? Is Isha still on under you?
Isha?
Okay.
Okay, so just because Zane doesn't have that much time, we'll just talk really quickly about the brachial plexus. The brachial plexus starts as roots,
Okay.
so those roots correlate to the myotomes and the dermatomes that I'm sure you're gonna go through in like 30 seconds. They are found in the front, they cross through the scalenes and then dip under the clavicle. So if you're having problems, with any of the myotomes that Dwayne is gonna cover, it could be coming from a root level, and then the second problem of roots can help with that. Do you wanna just go through the myotomes? I feel
Well,
like
I
it
was
can be.
just going to have like a demonstration, because I was thinking this is more practical application, doing very quick dermatome, myotome screening.
Why don't you just do that? Yeah, I think it'll make more sense, because everyone knows what the brachial plexus is, so I don't wanna like preach.
Okay, alright, so if I have someone come in for cervical, if they're coming in for shoulder, and really any kind of upper extremity, I'm going to do my dermatome myotomes really quickly, during the evaluation. So, just as a quick demonstration, do you want, no, not you, you have shoulder issues. Alright.
Well, this shoulder's good.
Yes, that sounds great.
So we need to clear a table.
Let's clear a table.
Oh, coming this way.
Let's go this way.
You wanna use your high-low table?
Let's use a high-low table. Come on over, guys. Alright, so come on, sit right over here. Thank you
Put
so
on
much
auto
for
trap.
volunteering here.
Picking up the wrong person though.
So we're just going to do like a, you don't have short sleeves, but, well, we'll pretend you do. That's okay. So we're gonna do a quick strength test. That's just what I tell people, but we're gonna come right home. First thing I want you to do is go ahead and shrug your
It's
shoulders,
not.
right there, press down. Any pain with that? Alright, I'm going to bring this elbow out right here, bend it. I'm going to push right here, don't let me. Hold, good. Other side. So this is supposed to take, within 2 minutes doing this dermatomes and myotomes. And bend your elbow right here, hold, don't let me move. Hold, good. Push now, hold, good.
Have her change position for the flexion and extension.
I-
Position.
I can have her do this, but if I'm doing it fast,
Yeah, okay.
then I just do it in the same position.
Very good.
So that gives me a little bit more, mechanical advantage from up here. Especially if there is, I might change it positions if they're really, really strong, or if I do feel a little bit difference right and left and I wanna make sure that I felt it, I'll go ahead and change the position, go ahead and bring your wrist up like this, and then hold it right there. Go ahead and flip your wrist over. I'm getting extension and flexion, this one too. Hold it over, and hold. Push your right hands down. Don't let it push. Good, nice and strong. Good, alright, awesome. So, that's it. You're good. You're strong, fast. And then, for dermatomes, like, generally people wear short sleeves or they'll have some, a shirt under it, and I'll have them just kind of bring up their sleeves. So you want to touch on bare skin. You don't really want to touch through the shirt because it doesn't really tell you anything. But just for demonstration purposes, it's fine. I'm gonna have you put your hands right there, and I'm just going to, I'm gonna touch you very softly, and I want you to tell me if anything feels different right to left, okay? Different or painful? Same? Good. All good? Alright, so that's it. So, 2 minutes, dermatome, myotomes. I'll go ahead and get my here. Alright, so, everybody knows how to do range of motion, and, so I went through the SFMA course not too long ago, and Chris has too, and I found it to be a really effective way to go through and assess people. So for most people, no matter what they come in for, I have them go through this top tier, unless they're, you know, rather complicated or in a lot of pain. My personal preference is to break it down a little bit. Say they're coming in for some kind of shoulder injury or issue, they're in a lot of pain and they're elderly. I'm not going to make them go through the whole thing. But I'll go ahead and look at their neck and their shoulder really quickly. All right, Brittany, do you mind being the, or is anybody else want to volunteer? All right, Brittany it is. Okay, I'm gonna have you go ahead and take off your shoes if you don't mind. That way, we do everything the same way every time. So there's no variability if someone's wearing taller shoes or different shoes someday. I always have people take their shoes off. Okay, go ahead and stand up. I want you to put both your feet together. Here, I'll face up and face this way so everybody can see you. I want you to go ahead and bring your chin down to your chest. There you go. She touches. I'm looking at her spinal curve too, making sure. So hers is a little bit flat here and then a little bit rounded. So she'd actually get like a dysfunctional, non-painful for that one. Any pain with that one? Okay. I want you to go ahead and look up towards the ceiling, looking at 80 degrees range of motion. She is almost 90. If you look at her face right there. Any pain with that one? Nope. All right. Now I want you to go ahead and just look over the shoulder. Any pain with that one? And the other way. Good. All right. Looks nice. I'll move on to like some functional internal external rotation. So I want you to go ahead and with your left hand, I want you to reach to the opposite scapula. There you go. Go ahead and do it one more time. Down and back up. So I'm looking for like smoothness of motion. I'm going to ask her if she has any pain. I'm looking for a little bit of winging on this side. Go ahead and bring that down. Any pain in that shoulder? No. Okay. And then on the other side, same thing. She kind of has like a two-step motion instead of being like really smooth. Kind of like a yeah, just something. If I would take note of it. Yes, sir.
So, if one is unable to do that,
Right.
what?
Here's my scoring. Thank you for asking that. On the left-hand side there, so I have 4 categories: dysfunctional, non-painful, dysfunctional, yeah. Dysfunctional, painful, functional, non-painful, and functional, painful. So I just abbreviate that DNDP at the end of our
Like here, I can go here, and I'm not even thinking about
a little bit.
You
Yeah,
do
but they're
dysfunctional,
very level.
painful.
So that would be dysfunctional, painful. That is as far as in the pain though. See, I would ask, is it in the front, is it in the back? Okay, in the back.
Maybe it's all those years of going to parade or something.
You should be able to do it then if you're a
But
pretty
it's
rest. Yeah.
painful though.
So he needs to work on his breathing.
Sure, always breathing. So that's one. So I mean, that's already a quick assessment. And with SFMA, like we go through, okay, what, if we break that down, so this motion right here is functional, but what different shoulder motions do you have? You have extension, right? You're going back, you have internal rotation, and you have elbow flexion. So you can break it down. So if you're dysfunctional there, I can break down those 3. And I can do it actively or passively. If I have you laying down on your belly, and I have you lift your arm, and you barely go anywhere, and then I have you relax, and I'm able to lift you up, then it's not a mobility issue, then it's a motor control issue. So, I don't know, I think we'll have time to go through that. All right, second pattern, feet together. I'm going to have you reach over and touch your opposite side. I'm gonna have you turn around. There you go. I want you to reach right there,
Yeah,
good.
reach that far.
Hmm?
I can't reach that far.
Look what she's doing with her head. So she's compensating by like some forward flexion instead of being able to do it without. Yeah, so for that, I would look at flexion. I'm going to look at your external rotation and also your elbow flexion there to see which one's limiting it and if it's active or if it's passive, or, you know, if it's a mobility deficit or if it's a motor control deficit. Okay. So I'm just gonna do the upper extremities. The multi-segmental flexion is where you reach down and touch your toes. So I won't have you demonstrate that right now. Alright, so with SFMA, like after you do that top tier, they break down the different motions, just what I was talking about, like extension, internal rotation, elbow flexion there. But with shoulder, you also really want to look at the thoracic spine, because in order to do a lot of these motions, you have to have that like extension and rotation of the thoracic spine to get that full shoulder flexion. So, the first thing I would actually do is have Brittany, you don't mind, do you?
That's good.
Okay, I'm going to go ahead and have you get into, it's almost like a child's pose position. So you can get on the table, on your knees, bring your forearms together, right there. Good, bring your forearms together so they're touching, nice. So now I want you to go ahead and do this motion again on that side. I want you to turn your head to the right, and then I want you to continue to lift up and twist until you're looking at the ceiling. Nice. Okay, come on back down. And I'm gonna go ahead and kind of keep you in this tunnel. So I don't want you to move laterally this way. I want you to try it one more time. There you go. Very nice. So we want at least 50 degrees, and she has that. Like her thoracic spine moves very well. Okay, let's go to the other side. All right, go ahead. There you go. How does that feel? Any different from the other side? Okay, cool. So let's say she didn't have that range of motion. The second, what I would do next, I'd go ahead, get into that position again, on the other side. I do it passively. Like, okay, we're going to do it again, but this time I'm going to do that. I'm just going to brace you on this side, and I'm going to grab underneath your arm here, okay? Go ahead and relax, let me do it. There we go, wonderful. And some people will have, like, they can't do it actively, but I can bring it into them passively, no problem. So that would, if they have trouble with both, then it's a mobility deficit, right? But if they can't do it actively, but I can do it passively, then it's motor control. They just don't have the ability to do that. Okay, you can go ahead, come on up. Let's go ahead and do, I'm gonna have you lay down on your belly. Do you guys have any questions? No? Do you think this is something you would use? Yeah?
I'll use that thoracic stretch on myself. I need to work on my thoracic
It's
rotation.
nice. I mean, like for an intervention, you can get in quadruped and do it actively.
I do that on myself.
I do that one too. I do that one too. It's a good one.
That's good.
It does. All right, I'm gonna go ahead and have you scoot over to the side so that your arm is hanging off the bed, right there. And if I wanted to check her flexion, I'm just going to ask her, go ahead and reach up as high as you can. Very nice. So I'm looking to see, like if she was face down, you can relax. If she was face down, does her arm reach her ear? So that is full range of motion. Good. And then if it was, hers is good, so I would leave it alone and I would move on to the next. But say it wasn't, I'd go ahead and do it passively to check it. All right, here we go. Let's do external rotation. There you go, nice. So we're looking for about 90 degrees there. She's pretty close. I usually have my Goni too, especially for initial eval, so I can have actual data. There we go. That's nice. And what you prefer? This part in. Good. So we're looking for, is it 60 or 70 degrees at SFA? No, once.
Internal?
70, right?
I think it's 60.
I think it is 60.
It's
I
90
learned 70 in
plus.
school,
Yeah,
but it's 60.
it's a 150-degree arc.
Let me see. Where's my Goni? Here we go. Yeah, you're good. You're 65 degrees there. Alright, relax. So from here, I'll test extension. I want you to go ahead and bring your hand up to the ceiling. There we go. For 60 degrees of extension. Relax, and I'll do it. So that was passive. Look how much more she gets passively than she gets actively. Measure that active too. Go ahead and raise it up. Yeah, just a little bit short there. 55 degrees. Not too bad at all. All right.
Broken.
No, you're not broken. You're doing awesome. All right, I'm gonna go ahead from this position. I'm gonna check elbow flexion. Go ahead and touch your thumb to your shoulder. Perfect. And then from like a flexion position here, touch your thumb to your shoulder. Good. Almost a little bit harder. All right. Cool. I think I hit all of those. You know, sometimes those first two, you can do it. You tell me, Chris.
Mm-hmm.
So when you get someone prone like this and you have them do like active, passive, you have them do the movement, have you ever had them be able to do it prone when they couldn't do it standing?
No, I mean, but it's possible because it could be a postural thing.
Yeah.
Yeah, and I think that's why we assess it from that position.
Yeah. So I'm not perfect and I often skip that because clinically I just don't see it.
Yeah, I've never seen it.
I've never seen it, and it takes a little bit more time out of my assessment. But if you're doing things, and I should have showed you guys how to do it 100% correctly, I would have her, the first step would actually be, okay, Brittany, while you're laying there, I want you to bring your arm back and touch the other one, okay? Good, and relax, so that's actively. Now I'm going to do it, so just relax your arm and bring it up and back. So that's a little tight right there. So after that, you can go ahead and sit up. I mean, you can do like check joint mobility too to make sure the glenohumeral joint isn't hypomobile. You can, I like to, let's say this person comes into the clinic and they actually have radiculopathy, so they have numbness, tingling, and anywhere in their upper extremity. You can do a quadrant test. You guys aren't really taught those, huh? Like Sperling's or quadrant test. Can you assess them? Can you rule out the neck?
18 years ago, I could not tell you. These are the new grads that can tell you, but I mean, I was taught with OTs and PTs all together. So we did all our physiology and everything together. So but I can't tell you what's taught now.
So
Shoulder.
if you're doing a shoulder assessment, do you clear the neck?
I haven't personally.
But you didn't learn it either. That's,
One of my friends worked with somebody with cervical radiculopathy, but she worked with a PT. They did co-treat.
okay, okay.
Joy and Travis, I knew you guys were the COVID class, but did they do anything like that with you guys in class?
I don't remember.
How about you, Travis?
We assessed like range of motion, but no more than really that, just kind of looking for a deficit. And then like in a clinical sense, when I was working with my one field work, most of our like neck or cervical patients did PT and OT. They had a lot more issues going on, so the PTs kind of took the reins on that, and we just took upper extremity.
Yeah.
We talked about like range of motion and MMT, and if you see anything abnormal, then it could be a neck issue, but not what to do.
Well, just, I guess like a Sperling's test, would you guys be able to do one? Say someone comes in and they have, some shoulder pain here, and maybe their neck range of motion is pretty limited, and, you wanted to determine whether or not that was influenced by nerve roots, cervical nerve roots. So, what I'm going to have you do is tilt your head back, and so this is more like closing off the foramen there, foramen, and I'm pressing down. So what I'm doing is I'm getting her in side bending, extension, and I'm doing a little bit of axial loading. And if someone says like, oh yeah, that brought on, I mean, sometimes it's just in their fingertips, and you guys see that, like, that brought on my symptoms. They're like, oh, okay, well, that's positive then. Or even in my shoulder pain, you can call that positive. And along with there's a cervical radiculopathy test cluster where it's like positive if it's like rotation is less than 45 degrees towards the affected side. You have like a positive Sperling's or quadrant test. This is what I just did with you right now. Like the ULTT is positive, and there's one more.
Traction. Mm-hmm.
Relieves it. So with a little bit of traction and sitting, you can grab someone on either side of the head here, go underneath like the occipital bone, and just do a little bit of gentle traction. There you go. How does that feel? Feels good. Most people say it feels good. So, and does that relieve your symptoms? Sometimes if I can't get it in sitting, sometimes when they're supine, I'll do a little bit of traction. People will tell me like, oh, my tingling, it went away. I'm like, okay, well that's positive.
Are those similar to like the thoracic outlet test too? I know you put I haven't talked about them since school, but maybe it's not thoracic outlet, but where you put the pressure on the shoulder when you relieve it, if some pain is gone.
Those are different.
Yeah.
Those are different from the clavicle.
Okay.
Yeah, rather than
Different. You're not looking at the upper cervical spine.
So clearing the spine, I was taught flexion, extension, lateral flexion, and rotation. Yes, no? Or with some pressure at the end. A little bit.
overpressure.
Yes.
Yeah, that works.
And check it and make sure the nerves are doing a neural tension test, making sure they're clear as well.
So the tension we do on the table.
Yeah, ULTTs.
Yeah, if they bring their head towards and symptoms start to relieve, then
I'm sorry, it's active range of motion, passive range of motion with overpressure, PA glides, and neural tension test. If all those are negative, then this spine is clear. Yeah.
So thanks for this, guys. For us, what I'll end up doing is,
I know that part about flexion, extension, rotation, and lateral flexion. I often go get a PT to help clear the spine for me if there's an issue, because it'd probably take me 30 to 40 minutes to try to figure everything out when I can just walk over here and say, Amy, Johanna, Chris, can you clear this for me? And then you guys will say, ooh, yeah, this one might need the CPT, or great, you guys can continue what you guys got going on. I think we've had a few patients we've collaborated on.
We've done that before. I've done that with a couple of different OTs where they've asked me to come over, and I'm like, okay. So, yeah, don't hesitate to pull us over and ask if you suspect cervical spine involvement. All right, let's see what else I've got. We have more time? No, we're out of time?
not